So our next session, in the US, electronic prior authorization has been around for more than a decade. And the Canadian version of this technology promises to improve overall timeliness and efficiency. Today's second session will discuss some key differences between various EPA options and explain how plan sponsors can benefit from simplified administration without compromising effective drug plan management. This session will be presented by Jason Kennedy, Director of Health Business Consulting at TELUS Health, and Tara Liu, Director of Drug Strategy at Canada Life. Welcome to the virtual stage, Jason and Tara.
Thanks, Francesca.
Thanks.
So thanks for that kind introduction, and thank you to Benefit Canada for having us here today. Good morning, everyone, and I'd like to say that Tara and I are excited to share with you our thoughts on some considerations around the idea of digitizing the prior authorization process and what it can mean for you and the stakeholder community, including plan sponsors in attendance today. Now, for this sort of session, we could drone on for hours, but fortunately for you, we only have 20 minutes. And as luck would have it, Suzanne laid a great foundation and provided us with background that really allows us to build off of. So really fortuitous that we had Suzanne going before us here today. Now, by way of housekeeping, Tara and I will be going back and forth throughout the presentation, and we hope you find it informative. So as an agenda, some elements we'll be looking through to talk through over the next 20 minutes, really provide a general overview, discuss some of the challenges, but also try and understand through that lens what some of the benefits could be in digitizing this process, what some benefits for the plan sponsor are, obviously, and then we'll look to close it out. So just to ground us here, I think, this is what we would consider a simplified view of the prior authorization process. It's a little bit historic as well, but even in a simplified view, you see there's a number of steps in the patient journey. We have the physician to the left who prescribes the medication, the member receives it, goes to the pharmacy, submits the claim, it gets declined for prior authorization. Pharmacist advises the member has to go to the physician, we have to obtain a form, complete it, and the cycle begins. It turns out though that the journey is even more complex than this. This is a simplified view meant to ground us, really to show that and be illustrative that there's a lot of handoffs. And not only are there a lot of handoffs, but it can be time consuming for various stakeholders. But it's a valuable process as far as cost containment goes. So we wanted to ground this visual that the process itself and the handoffs that we have would benefit from digitization. But there's other challenges that surround this process, and that compounds the challenges of the handoffs. So Tara will start next here to help us understand why prior authorization is a useful option and share with us some other factors contributing to the challenges in the process. Tara?
Thanks, Jason. So I know prior authorization is top of mind today, but it doesn't necessarily come to the top of plan sponsors' mind when thinking about cost containment strategy. Key decisions are typically around formulary choice, co-insurance, deductibles, breakpoint insurance, etc. But prior auth is always there in the background, and it's a key tool in the toolkit for plan sponsors' drug plan management. And it's essentially standard now. For these complex drugs, it is often the only way to ensure appropriate use of the medication. As a plan sponsor, if you're paying $20,000, $50,000, or $500,000 annually for a medication, you want comfort knowing that it is being used for the right patient at the right time. It allows the ability to ensure more cost-effective alternative medications are considered and tried. It ensures that clinical guidelines for step therapy are being followed, and patients and doctors aren't trying to bypass the standard, more cost-effective medications to try the newest med on the market. Prior authorization also offers the ability to look at other coverage options, such as provincial coordination and coordination of benefits handling between spousal plans in much more detail. By having a manual quote unquote stop in the process of adjudication and dispensing at the pharmacy level, payers can take those extra steps to mitigate the risk of paying for an inappropriate high cost claim. Next slide, please, Jason. While prior auth is a great tool for plan sponsors, it does come with its own set of challenges. The pharmaceutical pipeline is focused on high-cost specialty drugs. We now have specialty medications being used in more chronic, highly prevalent conditions such as chronic migraine and cholesterol disorders. We have a volume that is growing quickly with an aging population, and we tend to see about 25 new drugs added yearly to a prior authorization list. Add on to this the complexity and the many different administration models amongst payers. Payers are asking for lab reports and drug histories, leading to admin effort to just submit the form. And the complexity of criteria is expected to increase in the future. Many of these reviews require health professional involvement by payers as well. We can also have rework created by missing information, incomplete forms, ineligible forms. And this creates a back and forth between payers and doctors and plan members. This can result in delays, which results in calls to the call center by plan members following up on the status of their claim. As Suzanne mentioned in her presentation, when payers are reviewing drugs, on top of the clinical and cost effectiveness reviews, all of these factors are taken into consideration as well. How many prior auth requests are anticipated? If there's a renewal, that doubles the amount of work coming in. How complex is the criteria? Do we need a healthcare professional to review? Is the risk mitigation enough to justify the process impact to the plan member? To top this off, this is all typically done paper-based through fax. Yes, it's almost 2021 and we're still using fax with some email submissions here and there. I'll turn it over now to Jason, who will discuss the benefits of digitizing this process.
Awesome, thanks, Tara. So, I think Tara did a great job of layering the challenges in that exist on top of the multiple handoffs. But, to try and understand the benefits of digitizing this process, I think we also have to kind of consider what digital means. And it can mean different things to different people. When you consider what EPA means, there's a host of different models and views. So again, to try and ground us here, we'll list some options for consideration, but also what they could mean to the process and the stakeholders. Let's just start here. Today, as a paper-based process for payers and reviewers, it's essentially a swivel chair process. And what that means is that information is provided and reviewed in a form, and that form there's a decision made, and then there's another process that happens to add that exception or trigger a communication to the member. But what if that output came in a consumable fashion? And by consumable, I mean something in almost like a data feed that another application could receive and then act on. Another thing we can consider when we're talking about digitizing the process is like a real-time assessment. So what if we could automate that decision step? So providing a recommendation for coverage as to say, should this medication be approved or should it be declined? Conceivably, if we could do that, could that remove a step from the payer's review and the time associated with that? So if you have an output that's in a consumable fashion and a potential decision, can you now run an automated process that could either trigger downstream communication to the client or to the patient support program, or where approved, could we run something like a macro or robotic process automation that could aid the automation to add the exception? And in doing so, speed up the process, but also reduce some data entry errors as well. All of these areas look to address the challenges that are arising from the complexity and the admin effort. And we see this as an opportunity to potentially mitigate. Now, another area we can consider is mandatory fields. It sounds really simple, but if you've ever tried to buy something online and you forget to add in your postal code, or if you forget to add in a number on your credit card, you can't proceed. So, if there's an option to make certain fields mandatory and ensure the information's there, we can eliminate waste. What if we can standardize some of the output to ensure that there's no illegible fields? So this idea that I can't read what's being written, or there's not enough space to kind of fill in all of the information. So these are kind of simple problems you'd think, but digitizing can solve some of them. And it's not necessarily insignificant. We have some anecdotal information that says, anywhere from 5 to 10% of rework is created from missing information or information you can't read. And think back to that initial view I showed. What does that do to the stakeholders from that first view? It creates rework for all of them. And most importantly, what does that mean for the plan member? We see each of these having value unto itself. But our view is that in an accumulated fashion, it creates the opportunity to address the opportunity cost, where we see certain high cost or high complexity molecules and go to other molecules where volume may be prohibitive. We don't see that as insignificant either. And we see this can benefit patients in scenarios where the option today is no coverage at all. So all of this creates the potential for a digital stream that allows for richer foundation for data and analysis, but also reduced timelines to decisions for patients. And we see that as a good thing as well. Now, again, just to talk about the benefits of digitization, as I mentioned a couple times now, it means different things to different people, but there's this notion of the digital process, and then there's this notion of the digital data. And as I said here, a digital process can reduce time to a decision, which can create theoretically faster starts for a patient or a member, to create greater adherence and persistence with them, which ideally leads to better outcomes. And it can reduce the rework and time spent on clarifying items, which can mean greater overall satisfaction for the various stakeholders. Tara, could you take us through the information on the right to explain what digital data could mean to carrier?
Sure. The paper process has served us well for many years, but being able to take all that information from the form and having it potentially as data points will unlock richer analytics and insights for a carrier. Data can be contextualized and give us information. From that, we gain knowledge, that insight and experience and understanding that allows us to improve decision-making. For examples, what drugs should be kept on or removed from a prior authorization list? With digital submission, all the key information is there, and there's opportunity to integrate with adjudication and make an end-to-end digital process. More data also allows payers to inform future plan design options around prior authorization, formulary management, et cetera. Thanks, Jason.
Just kind of move it over. So, let's assume for a second that we've made the case. We're doing this quickly here, but we're making the case why digitizing this paper process with many handoffs and rework cycles, why we think that it's a good thing to do. What can we learn from experiences elsewhere? Well, I think it is important to inform based on models that exist and kind of ground us in our future direction. But, if we look at other markets with EPA, in some cases, they're more than 10 years ahead. And that's significant, and we'll come back to that. But also what we've seen is that there's sometimes a situation where multiple players exist, and each have their own ideas on what a digitized process works, going back to my comment earlier, and have different trigger points. So what that can mean is, in some cases, they pull directly from the EMR in a more automated fashion. In some cases, the EMR launches a portal. And in other cases, there's a standalone portal. So all of these models exist. The other thing, thinking back to 10 years ago, when this kind of started, was it was really targeted at small molecules. So small molecules such as Celebrex. Celebrex at the time was a COX-2 inhibitor for arthritis. It used to be on PA programs, and the question was, have you tried naproxen or a normal NSAID? And that was the level of complexity. It was pretty binary, and it was prescribed by family docs. So that informed the strategy that we've seen evolve in other jurisdictions. The other piece I think that's important to understand here, divergence in this case has created complexity, and that complexity I think has resulted in challenges getting complete adoption between the number of family physicians, the multiple portals, the multiple sets of criteria. This has resulted in a situation where even in areas where EPA exists, there's data out there that says anywhere from 35% of the forms are transmitted online. So again, is getting to 100% completely reasonable? And is there other ways of getting to 50%? The other thing that's important to understand, like I said, they started 10 years ago, but if you want to inform how to proceed in today's environment, you kind of have to look at today. And I share the slide almost tongue in cheek. You know, a lot has changed in 10 years. We even have mRNA vaccines coming, pretty cool. But we still don't have real EPA in Canada yet. And, you know, so that hasn't changed. But, you know, in this case, we have a landscape that has changed around us. So we have specialty molecules that are now predominating the prior auth process, but also the complexity of that criteria. We have complexity for the treatment of the patient and the cost, and that has resulted in the emergence of patient support programs. And they've embedded themselves in the patient journey in a way they weren't 10 years ago. So when you think of that chart at the beginning, where was the PSP? We didn't even consider for them. So how are they accounted for? And then the idea, as Suzanne kind of mentioned, it's largely specialist-based. So, you know, how do we account for specialists? And in some cases, the fact that they may practice in hospitals and clinics or, you know, other different settings. And the other piece is if we wanted to take an EMR approach, you know, there's 90,000 physicians in Canada. What does that change management look like? And what does a business case to support that look like? So some key considerations in this case, you know, for me, EPA or digitizing the process, there's the technical component, but there's the real like business component that is all about the change management. How do you negotiate adoption to get to, you know, critical levels in a way that can kind of navigate those complexities I just showed on the other slide? How do you take those learnings and apply them? And like I said, it's both a technical and a business process. And I think it's almost more a business process than a technical process. So when we talk about the path forward, how do we do this in such a way that the wins are greater than the effort? And how do we do that in a way to start where physician intrusiveness is kept to a minimum to reduce impact on this key stakeholder group? So EMR, everyone wants to go there, but how do you do that? Which model do you use? How does that fit into physician behaviors and designed in a way that's frictionless? Because it's not just a technology problem to navigate. How do you navigate consent in that world? You know, where you need the physician, the plan member, and in some cases the patient, depending on the PA program requirement. You know, from a criteria point of view, not all criteria can be automated in the current state. Forms with free-form text pose inherent issue with automating. So perhaps it's about how we find a balance to ensure we automate what we can to streamline the more common molecules, but also use that learning to evaluate the benefit of automation and the value of free-form text in decision-making. Or do we take the savings, you know, from the automation side of things to preserve that time to be focused on those more valuable, high-intense cases? So, you know, I think, and the last piece tying into the workflow is really to suggest that, you know, this is a business process as well. So we want it to be almost frictionless where we can make it. And how do we iterate based on that? So I'll leave it now with Tara to bring some of the benefits closer home.
Thanks, Jason. You've clearly outlined there's many benefits of digitizing this process. And for plan sponsors specifically, it improves the plan member experience by increasing the time to a decision. As that is some of the frustration for members. It's the not knowing and the back and forth that can happen with missing or ineligible information. But improving a member experience doesn't mean that there's a lessening of cost mitigation. That level can be maintained and in fact able to improve. By digitizing and removing some of the administrative work on drugs that are more straightforward, payers can focus the deeper reviews on the more complex cases. It also opens the door to increasing the number of drugs that require prior auth that administratively are unachievable today. By simplifying the process and making it digital, payers and plan sponsors can broaden focus to lower cost, higher volume drugs that do have more cost-effective alternatives and clear step therapy guidelines that recommend certain drugs be tried first. As Suzanne mentioned, decisions on what drugs are added to prior auth are complex, and some of the factors are administrative burden to the plan member, physician, and payer. With digitization, those factors are less of an influence and allows payers and sponsors to go to areas where we can't administratively today. Jason, the next slide, please. So we've heard a lot this morning so far on what is prior authorization, why it's important, and what are some of the challenges with it. I hope that we've conveyed that the benefits and value can be unlocked by digitizing. Keys to success are leveraging technology and having strong change management principles to support it. An advantage of having other jurisdictions go first is that we can take their learnings and apply it in our unique Canadian landscape. And finally, digitizing the process has benefits for all stakeholders, including our plan members, plan sponsors, payers, and physicians. Thank you for your attention today, this morning, and I'll pass it back to Francesca, and Jason and I will be happy to take some questions.
Thank you so much for your presentation. We do have a few questions coming in. The first one is for Tara. Tara, do you think you could automate prior auth adjudication, or will it still need a human touch to review and decide?
That's a great question. I think there will be some drugs that can be automated in the future. You know, there's some drugs that are quite complex that need that human review, that need a healthcare professional review because they're, you know, a little bit more gray. But I definitely think there are a lot of drugs out there that can be automated.
And this question is, I guess, for either of you guys. How does the digital process integrate with the pharmacare provinces?
I can take that first.
Sure.
I would say there is no formal integration in the way it works today. What we've got is an output and a business process that triggers off of that output. So if that business process contemplates pharmacare, you would continue to contemplate pharmacare. If it doesn't, you don't have to. I would say what we're keenly aware of and acutely aware of is in Quebec, the requirement for RAMQ forms to be available to be processed for citizens as well, in addition to the standard bilingual forms that would be available for those same molecules by a carrier. So, you know, you can consider that piece in that manner, but I would say the pharmacare piece and that coordination, that happens downstream of the output.
Okay, we have a couple of questions coming in around physicians. How can you engage doctors to participate in EPA?
I'll take a stab at that. I would say, you know, first and foremost, we recognize them as a stakeholder group and a pretty key stakeholder group. I would say what we're trying to do and what solutions may want to contemplate is how to involve them to the minimum level required to achieve the same benefit. So, you know, I think that goes back to the design theory and how you want to design this. As far as engagement, we're looking at multiple approaches that consider sort of general education, field case manager work through the PSPs, as well as, you know, now considering how to work with key opinion leaders in that format. But again, I think part of it is level setting as well on, you know, what we're actually asking and how little of an intrusive nature it is versus their current process today, and how, you know, we see the benefits in this as well.
Speaking of benefits, there's a question around what would the volume of paper-based PA requests you currently receive, what would be the volume, and what would be the turnaround time from receipt to communicating a decision to an employee?
Do you want to take that one, Tara?
So what's the volume of paper we get today?
Yes, I think that's what the question is, yeah.
Well, everything is paper today outside of our pilot. So I would say 100% there. And then the turnaround time would be obviously dependent on the type of drug that we're talking about. So it's hard for me to give an exact answer there, but yeah.
Okay. Speaking of drugs, as lower cost generic introductions reduce drug spend for PA products, would that factor into a decision to revise PA?
Yeah, like I think anytime, Jason, I can jump in here and feel free to add in. But yeah, anytime we have new entrants to a class that has multiple drug products for us to review, that definitely takes into consideration, right? Have prescribing practices changed? Are certain things now first line and there's no step therapy anymore? Does the cost then lower to the point where, again, that risk mitigation isn't needed? So yeah, if there's new lower costing entrants that come to the market, it definitely plays into that multifactorial decision that carriers and PBMs have to make on what goes on their prior auth list.
Okay, another question we have coming in is, how does the EPA process improve treatment adherence?
I can take a stab at that, Tara, and if you want to top up. I would say, from a TELUS perspective, I would say part of what we are looking to do globally is digitize the patient journey. In this case, with a pilot, we're looking to measure that. The pieces around timelines and the pieces around adherence. There's data that suggests that the sooner you get patients on medications, the reduce risk of abandonment if it is a time-consuming process. And as kind of Tara mentioned, it can be somewhat different based on the medication, but it can also be different based on the carrier. So again, if we can create a little bit more in terms of standards around that, we see that there's benefit in that fashion as well. It's just really time to getting the patient on the medication. Now, we're hoping to evaluate that though.
Jason, you mentioned actually just now data. Does the data captured open the door to outcomes-based agreements?
I think it's hard to say what the data will open doors toward. Other than we realize that there's a lack of it today, or if it exists, it's hard to mine. And so freeing that or liberating that, as some people might call it, is kind of the gateway to doing other things with it. We hope to be able to speak more intelligently on what those could be, but right now it's a lot of theory.
There's another question here, and again, either of you can take it, perhaps Jason, and it has to do with step therapy. Okay, do you see the future where proactive disease management can take place? For example, with step therapy, if a patient is not responding well, do you think the EPA process with enough insights could trigger a conversation with the prescriber from the carrier's own panelist? Questions.
I would caution turning EPA into an easy button. This is a really complex process, lots of stakeholders, lots of kind of variables that, until you dig in and understand some of the behavioral components and workflow components, it's tough to really appreciate. I don't think, I think part of grounding the expectations and success of what this looks like is grounding it in the scope. And I don't see that as an initial endpoint for us, for sure. What the future holds, again, data will unlock opportunity, and we'd love to get there.
Okay, well, listen, that's all the time we have for questions. Unless either one of you wanted to make one final, takeaway, I think we've pretty much covered the time frame here. So thank you so much to both of you for your presentation, and thanks for joining us today.